Welcome, everybody, to the last Independence Age Friday briefing of 2021. Unfortunately, we are entering the festive season with less than joyful hearts as the pandemic surges. Yesterday, the UK recorded a staggering 88,376 new coronavirus cases, the highest daily number since the start of the pandemic. And the real figure we know is likely to be even higher than that, as there's currently a shortage of lateral flow tests in some areas, and PCR tests are taking much longer to process too. In some regions, the doubling rate of the new Omicron variant is down to less than 2 days. So unfortunately, we can expect things to get worse over the coming weeks. And this raises some incredibly difficult questions, of course, at this time of year about how much we should be altering our plans in the lead up to Christmas, and also what kind of pressure the increasing case numbers will end up placing on the already straining NHS. On Wednesday, Independent Sage issued an emergency statement calling for an immediate circuit breaker and some additional measures to contain the spread of Omicron before Christmas. Professor Christina Pargell is going to say a few words on that after she's presented the week's numbers. In a week where we've seen the Chief Medical Officer being publicly criticised by an MP for answering questions honestly, we'll also be talking a little bit today about the relationship between policy and science. We'll be discussing how we can effectively engage public opinion, something which has never been more crucial. Professor Tallulah Oni will be leading the discussion there, with special guests joining us today: Justin Pankhurst, Associate Professor of Global Health Policy at LSE, James Wilsden, Professor of Research Policy at the University of Sheffield, and Kat Smith, Professor of Public Health Policy at the University of Strathclyde in Glasgow. But first of all, I'll hand over to Professor Christina Pargell for the latest facts and figures. Christina, you have the floor.
Thank you. Right, so welcome to today's briefing. So I'm going to start this time with an Omicron update, then go through the national picture in terms of cases, hospitalizations, deaths, and vaccines, say just a couple of things about testing, and then spend a little bit more time on London for reasons that will become obvious. And then just end with the emergency plan that Alice just mentioned. So Omicron is spreading across the world. This is the proportion of sequenced positive PCR tests that are Omicron by week and by nation. And this only goes up to the 11th of December. So this is out of date, but you can see that it's most prevalent in Scotland and England, and lowest in Wales and Northern Ireland, but it is increasing rapidly in all home nations. This is just the plot for England showing how Delta, which was 100% of cases just a few weeks ago, is now being rapidly added to by Omicron, which as of the 13th of December was 40% of cases. It will now be the dominant variant in England. And it was only 3 weeks ago today that the WHO gave it its name. That's how fast it's been. And unlike the spring when Delta took over Alpha, Delta's not really declining. Delta's quite flat. So this is a new big Omicron pandemic on top of a high Delta pandemic. If we look at it regionally in England, this is from Sanger data. You can see this increasing in all regions, but by far the highest region at the moment is London. It's now, as of the 13th of December, it was 60% of cases in London. It will be more than that now. But so that's why I wanted to look at London. That gives us an idea of what will happen to other regions. It will become dominant in every region in England and the other home nations. The UK HSA released this estimate yesterday or Wednesday, doubling times for each region. So that's how long it takes for the number of cases to double. And it's kind of a measure of how rapid the exponential growth is. Now, in comparison, when Delta was taking over Alpha in the spring, it was doubling every week. And that was very fast. When COVID first arrived in England, when it was first really spreading last March, its doubling time was about 3 to 4 days. The doubling time of Omicron is less than 2 days. It is so quick. It means that if you wait just a week to make a decision about something, the whole thing's got more than 8 times worse. Now, it can't keep doubling at that speed forever, but we don't know when it's going to stop. So Imperial College released a report on Omicron today, looking at their Imperial data where they randomly test, several tens of thousands of people every week. They also report by far the highest rates in London and also in 18 to 29-year-olds. That's where it's spreading the most. They've looked at reinfection and show that reinfection with Omicron is 5 times more likely than it was with Delta. That basically means that previous infection is not very protective when it comes to getting infected with Omicron. They've also shown that 2 doses of vaccine, whether AstraZeneca or Pfizer, do little to prevent Omicron infection. A booster does help. It does make it's a lot better than 2 doses, but it's still not as good as the booster would have been for Delta. However, vaccines should still help significantly against severe disease, and that's why we're trying, firstly, to vaccinate people and then to boost them. But the report concludes that they find strong evidence of immune evasion, both from natural infection and from vaccine-induced protection, and this is for infection. What's more worrying as well is that they say that there's no evidence that Omicron is less severe than Delta. So they say at most, their data says if there is any difference in severity, it's not big, it's a small difference. So we can't rely on assuming that Omicron is going to be much milder than Delta to get us out of this problem. And what seems most likely is that what's happening in South Africa, what they're seeing is the benefit of a lot more immunity between their Delta wave and their Omicron wave, reducing hospitalizations, just like we did between the Delta wave this summer and the Alpha wave last January. And it's not about anything to do with Omicron, it's to do with the fact that they had a lot more immunity, mostly actually from natural infection. So the national picture. As Alice said, the UK is now recording the highest cases ever seen. The highest previously was in January when it was almost 70,000. We're now almost 90,000. Expect that to go up. Susan Hopkins said that we should be expecting to see quite staggering numbers over the coming weeks. If we look at it by nation, you can see that increase is driven entirely by the countries where Omicron is most prevalent, so England and Scotland. Northern Ireland and Wales will follow, but they're probably a few days or a week behind the other 2 nations. In terms of hospitalization, it's not feeding through to hospital admissions yet. Again, it's only been 3 weeks since we even heard about Omicron. It's going to take time to show up in hospital admissions. This is not a sign that everything is fine. Admissions are creeping up in England, and that is from Delta. That's not from Omicron. This is hospital occupancy. I wanted just to show this plot from the ONS infection survey today. Again, it's quite lagged. This isn't about Omicron, but this is just showing the age profile of people who are infected in the week to 11th of December. And in any other week, we'd be saying a lot more about this, but I just wanted to highlight that the rates in primary school children, almost 6% tested positive that week. This is exceptionally high. And of course, primary school children are unvaccinated. Schools now are either broken up or they're about to break up. But when we come back in January, this will be a very vulnerable population to reinfection by Omicron. And the same for secondary school students. We have to do something about this before schools go back in January. This is just looking at the number of admissions by day in England. You can see admissions are going up and have been going up for the last 2 weeks. Again, this is Delta, this isn't Omicron. Omicron will come on top of this, starting probably from next week. What is quite worrying is that the most recent week has shown a big jump in basically COVID outbreaks within hospitals. And there are anecdotal reports of Omicron spreading very rapidly in wards simply because it is so infectious. So this is something that we're going to have to keep an eye on and hopefully, upgrade the PPE the healthcare workers have access to. In terms of deaths, again, they're staying well over 100 a day on average being reported. They're flat, but again, we would not expect to see any increase in deaths from the current increase in cases for several weeks. So again, this is not a sign that everything is fine. This is what we would expect. And this is just, I wanted to highlight how we're doing with booster doses, since that's kind of the big effort right now. The number of booster doses given every day has been increasing markedly just over the last week, and we gave over 700,000 on the 15th of December. So we're now almost matching the number of doses that we were giving at our peak back in February and March. This is good news. Boris Johnson wants to aim for 1 million. We are going to have to keep going at that rate all the way over Christmas if we want to meet the target of vaccinating as many adults as possible as soon as possible. On testing, I just wanted to highlight where we are with lateral flow tests and PCR tests. This is the number of PCR and lateral flow tests every day since last October 2020. You can see these spikes in lateral flow tests that kind of coincide with the returns to school. But just over the last week or two, the demand for lateral flow tests has gone massively high in the UK. And I think this is partly because cases are going up also, I think, because people are starting to test more before they're going out and seeing people, which is a good thing, and we should be encouraging that. In terms of PCR tests taken, we are now doing more PCR tests than we've ever done in the pandemic. The most recent day on Wednesday was 480,000 tests were processed. But we don't have unlimited capacity. Just up to the week 12th of December, so again, this is a little bit delayed, you can see that the times to process tests, this is a proportion of tests received within 24 hours of doing it, this is coming down. And so we are going to start seeing delays in test results being reported. And as case numbers go up, as new infections go up, it is likely that there will soon be a testing crunch. So it will be harder to access testing if you have symptoms. And that means that daily case numbers will no longer be reliable indicators of new infections. So that means that it's quite possible that case numbers might stay flat and really high. I don't know exactly how high, and not go up or down. That doesn't necessarily mean that infections have stopped going up. It just means that we don't know. The best sources then of knowing what's happening are things like the kind of random infection surveys like ONS and REACT, or hospital admissions. But those are telling you what things were like a week or two ago. In terms of real-time data, you probably have to rely on the King's College Symptom Tracker app, which will give you the best real-time estimate of trend. But again, that's problematic, but I think that's pretty much where we'll be. We don't really have anything better than that. So just on London, this is the number of New England cases per region per 100,000 people per week. I've gone up to the 14th of December, so the last few days are not yet complete. They will go up. And you can see just the absolutely staggering increase that London has been having in the last week compared to other regions. It's not just about tests. Just in the last week, the positivity rate in London has started shooting up as well. And just looking at the most recent couple of days, this is from the dashboard yesterday, just looking at some boroughs in London, and frankly, far too many boroughs look like this. You can just see just in the last few days, quite how high the number of positive tests has been reported, like far higher than the January peak. As the REACT study said, the rates are highest in 20 to 29-year-old. You can see this extremely steep increase in London among 20 to 29-year-olds. And I think this is partly a function that the Omicron spreads so easily in social settings when you're inside. We've heard of several super spreader events internationally. And I certainly have several friends now who have COVID, where all of their friends when they went out now have COVID. But it's actually going up in every age group, including the over 60s and including children as well, who are coming down and are now starting to go up again. And unfortunately, we are seeing hospital admissions in London have gone from the lowest at the end of November now to the highest and rising in the country. Again, most of these up until a few days ago would have been Delta. It's now going to be starting to switch to Omicron. But what is kind of important is there's been a lot of conversation on, well, is it admissions with COVID or for COVID? Are people there because of COVID, or are they just, incidentally diagnosed with COVID when they get a test? Now, the NHS does publish that. They publish admissions for COVID by primary diagnosis. And this is looking at that data for London back to October. And you can see it's been very, very steady. Admissions have been very flat in London for weeks. But you can see that over the last few weeks, admissions primarily because of COVID have been going up. But also just in the last week, admissions that are not primarily because of COVID have gone up as well. So this is probably patients who either incidentally test positive, for instance, they've hurt their leg and they've come to hospital and they actually have COVID as well, or people potentially who caught COVID in hospital. So we saw before that cases of outbreaks of COVID in hospitals have gone up, and that would count kind of as an incidental COVID diagnosis. This is critical care capacity in London. This is last year, the orange. You can see the big increase in January as they upped capacity. This was 2019 to 20. You can see that critical care is already very, very busy in London, as high as it was a year ago. This is all diagnoses. This isn't just COVID. So there really isn't that much stretch if we get loads more admissions. And there was a paper that came out in the Lancet last night showing that we could be ending up cancelling tens of thousands of operations this year if COVID pressures get worse. The other issue with London that makes things a little bit concerning is that it is the region that has the highest proportion of unvaccinated people and the lowest proportion of boosted people. So we really have the least protection in London against Omicron, but really in all the regions, if you're thinking of the third dose as being that's the crucial dose, nowhere is over 50% for boosters. And if we look at it by age in London, unfortunately, only a third of 40-somethings have had their booster and only about half of 50 to 59-year-olds. So there is quite a proportion of people who are not vaccinated. And children or teenagers have very low vaccination rates in London. And finally, just to show this graph, that there's this big deprivation gradient. This is for London by age over 50. So you can see, 20 percentage points difference in the age groups between people who've had a booster by deprivation level. Now, this is the same pattern across the country. When Omicron hits, it will hit the most deprived communities the hardest because they're the least protected. And we already know from previous experience that they're also the most exposed. And so we can't just sit back and say we can live with it, because it's an unequal, it's an extremely unequal situation of who has to live with it. So to summarize, cases in the UK are higher than they've ever been, and they're rising rapidly. Omicron is now the dominant variant in the UK. There's increasing evidence that Omicron is very immune evasive and can spread very quickly. And even if Omicron has half the case hospitalization rate of Delta, if it doubled about 4 more times, the consequent admissions would be higher than last January. That's kind of what we're playing with. And that's if it's half as bad as Delta, and there's no evidence that it's any worse, any better than Delta. We know that doubling times are less than 2 days right now. So we need them to slow down, right? So we either have to hope that it peaks on its own, that we hope that the measures that are in place now is going to slow it down, that people's behavior is going to slow it down. And it might run out of steam, although there's absolutely no sign that it is, or we do something, right? Those are our options. And so independent stage think we should do something. We shouldn't just hope that it will peak on its own. And this is what we think we should do. We think that basically, the opportunity for early action has been lost. We advocated it, Sage advocated for it, but we've lost that opportunity now. So we're calling for an immediate circuit break from as soon as possible until next Friday, until the 24th of December. And that means going back to basically what step 2 on the roadmap was last spring, but that means no indoor gatherings between households except for bubbles, indoor hospitality and indoor entertainment are shut. It does allow outdoor meetings for the rule of 6. It does allow for outdoor hospitality. It does allow for indoor retail open with masks and distancing. And we also think, all close contacts of cases must isolate for 10 days, but with all the financial and practical support that they require. And we have to continue the vaccination effort. And then we should allow, limited mixing from the 25th to 28th of December. And at that point, to reassess, the government has to reassess where we are then in a week's time. Things are moving so quickly that I don't think you can really make plans now for what the situation is going to be in 10 days' time. But reassess over Christmas and then see what needs to happen. So I think what it comes down to is, some of the cases that we're going to see over the next few days, they're baked in. They're people who've been infected already. If they've been doubling over this week, we will find out next week. But we can't prevent that. But what we can do is prevent people getting infected next week, right? And by doing that, through this mini circuit break, we would save lives, we would protect the NHS, and we would enable people to have a much safer Christmas. And finally, just to highlight this, we have to accelerate vaccination across the world. If we leave people without the protection from vaccines, we're just providing the opportunities for new variants to arise. We've been saying this for over a year. It's still true. The UK has to support vaccine patent waivers and transfer of expertise and technology. And just to end on this slide of a new report that came out from Human Rights Watch this week, that there are over 100 firms globally who have the ability to make mRNA vaccines, so like Pfizer and Moderna, who currently are not allowed to because of patent waivers and technology transfers. We could change that. We could make more vaccine. It's not a zero-sum game. And I will end there.
Thank you. Thank you,
I meant to say I'm going to pass over to Tolly.
That's all right. That's all right. I picked it up. Okay, great. Thank you, Christina, for those thoughts. Really concerning, but really important to hear what is happening in real time and really underscoring just how much dynamic the situation is. As Alice mentioned, we're pleased to be joined by 3 guests today to delve a little bit into this interface between science and policy. The INDISH has been doing these briefings now for over a year and a half, and even in normal times, the relationship between science and policy is widely debated and contested. And so in an emergency, we have additional challenges of the pace of change, the consequences of actions, the challenges of information from uncertainty to misinformation, etc. And there's been a lot written about this, actually. And so today we'll hear from 3 experts on this topic. We'll be tackling it from the 3 corners of that triangle. So if you imagine a science, government and society triangle, we'll be looking at those interfaces of science and society, of science and government and society in turn. So with that, I'd like to first introduce Professor James Wilsden, who's the Professor of Research Policy at the University of Sheffield. James, we've had these press briefings since the start of the pandemic, really, and it brought to light to the public the role of science and scientists in advising governments. But of course, there's been a long history of this in the UK and globally, including, for example, the Bse Crisis and the inquiry that followed. You've worked in this space for a long time. Given your experience of science advice in the UK over the last couple of decades, can you share a little bit about your experience in the UK? What were recommendations that followed previous emergencies? Are we learning? What do we need to do? Over to you.
Thanks, Tolly, very much. Thanks for the chance to be here. Yeah, I mean, one runs the risk of sounding like one of those people who starts talking up their devotion to a band when they were playing, in the local pub, rather than now in a global stadium. But back when science advice was rather less debated and less fashionable in some ways than it is now. Of course, yeah, there's been lots of work done on these topics. I wanted to flag, a book 10 years ago now that colleagues and I wrote, edited on future directions for science advice in Whitehall, which is in some ways history now, although it does talk about the creation of SAGE, which was a new thing at the time. But one thing we did say there, and it was a point made as well by one or two outgoing chief scientists, was the need for what we described as a hindsight function in the government science advice system, as well as a foresight function. Foresight, at least back then, was a very big part of what the Government Office for Science spent its time and money doing. And the idea of a hindsight program, of course, would be to build in a more systematic mechanism to capture lessons, successes, failures from the recent or even more distant past, and build those into decisions and responses here today. Another point that we made again, which John Beddington and others made at the time as chief scientists, was for the need for more plurality in advisory structures in terms of disciplinary breadth, in terms of geographic breadth, national, international, and in terms of accompanying or complementing deep academic expertise with expertise grounded in experience and practice. All of these issues, of course, have been very prominent in the aspects of debate, and you, of course, as NDSH, have been at the heart of that. So these were points, many people made them, but certainly we found that they fell on rather thorny ground back then. I think if we look back very briefly, because I really don't have much time, for me, when this all erupted in the first place, the immediate kind of policy reference point, at least in my lifetime, was the Bse Crisis, which, although now we sort of think of it as John Gummer's daughter and a hamburger, when it first broke, of course, there was a genuine, huge uncertainty, a genuine concern that many people would die, and it created a real crisis in the British advisory system, and led some years later, when Labour were in power under Tony Blair, to a full public inquiry chaired by Lord Phillips, which produced a very good report in the year 2000, so 20 years before COVID. And that report looked in detail at these sorts of questions. And I again, don't have time, but key things that came out of it were the absolute critical importance of openness of the advisory system, transparency, far more explicit acknowledgement of uncertainties, clarity on the relationship between the advisors and the decision makers, and meaningful two-way dialogue between the advice system, politicians, and the public. And, in some ways, of course, we have seen aspects of that through this. We certainly saw less of it at the start, which is one of the reasons NDSage was of course, created. But I think it's an interesting question as to why, in the heat of a crisis, and perhaps that is the answer, but why we forgot everything that we thought we'd learned. And it's important to say that this wasn't just some sort of random report that came out and everyone forgot about. I mean, those documents were very foundational, key texts in the shaping of the British advisory system for the 10, 15 years afterwards. So I think it's an interesting question. And, for me, as we look forward now to the public inquiry that's to come, and we now know, of course, that Baroness Hallett has been named as the chair of that inquiry. This is one very important strand, both sort of in the sense of how we forgot what we thought we'd learned, but also how we now overhaul the advisory structures that we do have, some of which have worked better and worse. And I think, many aspects of the problems early on have definitely improved over the course of the pandemic, but how we overhaul them, how we ensure that we have structures and protocols that are fit for future emergencies and for the wider demands of robust advice, public accountability, and good decision making.
Thanks, James. One of the things you mentioned, sorry, Susan, did you want to say something quickly? I see your hand. Okay, no. One of the things that you mentioned was around the importance of communicating uncertainty, and we've seen from Christina's presentation today how just week on week so much changes, and how important it is to bring the public with one, in adapting to uncertainty. Use that to segue to Professor Kat Smith, who is Professor of Public Health Policy, University of Strathclyde in Glasgow, you've been working on this, particularly around that interface between science and society and public opinion. I see a comment in the chat from Greg Dance about the chasm between science and public expectations. So can you speak to us a little bit about this, because the public opinion is often cited as a reason for why interventions may be challenging or not implemented, and but this was a recommendation to foster better dialogue with the public back from the Phillips inquiry. So can you share some thoughts on your experience on why and how of better engagement with the public is so critical, and how it could be better done?
Yes, absolutely. I think there's two main issues with how policymakers have engaged with publics in the context of the COVID pandemic. So first, conversations between policymakers and publics are often separate to conversations between policymakers and scientific experts. So we've got a range of ways of making sure that decision makers are aware of scientific evidence, including scientific advisors and this group more externally and so on. And we've also got a range of ways in which publics feed into the policy discussions by their MPs, via issue campaigns, media coverage and opinion polls. But what we lack are mechanisms that bring these conversations together. And when that happens, policymakers are often trying to weigh up their understanding of the evidence and the scientific advice with their understanding of what publics will accept or how they will respond to particular policy options. So that they're trying to juggle that. And when doing this, policymakers often rely on media coverage, so their sense of public opinion via the media, and opinion polls. And these are valuable, but they've got important limitations when it comes to understanding what publics think about really complex issues where uncertainty is high, like we've been discussing, where there are trade-offs and where most policy options involve some kind of compromise for at least some people. Media coverage often tells us more about editorial lines and it's quite combative in format. Opinion polls involve asking people off the top of your head, having no time to think about this issue in any depth, or engage with the evidence or discuss with others, what do you think about this issue? And that might be fine for simple choices like who you're planning to vote for. But I don't think many people feel that's a sensible way of having a public conversation about an issue as challenging as the current pandemic. So as the pandemic stretches on and as publics tire of some of the restrictions or get frustrated, what we really need is considered dialogue with members of the public, where people are brought into conversation with scientific researchers and policymakers. And this allows us to get a sense of more informed, considered views and preferences. So options include things like citizens' juries, citizens' assemblies, where you bring diverse members of the public into conversation with scientists and policymakers directly over a series of days. And that allows people to hear about evidence, to hear about other people's experiences, to challenge scientists and policymakers, and to form more considered views. And for an issue as complex and challenging as this pandemic, I think we need more spaces like that. So, and what's really important in those spaces is they're not a one-way street. So it's not only about publics listening to and learning from scientists and policymakers, it's also about policymakers and scientists listening to and learning from publics. And in previous public health crises, we've repeatedly seen that policymakers and scientists often make assumptions that they have to about how people behave or what they think, and that turn out not to be entirely correct. And we saw that at the start of this pandemic in the UK, that certain policy options were excluded because there was a belief that members of the public wouldn't accept it, and that belief turned out to be wrong. So we desperately need more spaces for dialogue between publics, policymakers and scientists, spaces that are constructive and respectful and involve listening on all sides. And as James noted, you know, that point's been made before, but we just haven't done quite enough yet. We're starting to experiment with this with climate change, but we need more embedded mechanisms so that policymakers can turn them on in an emergency situation like this.
Thank you so much, Kat. Can I just follow up quickly on that? Given that James identified that this was something that needed to happen from an inquiry 20 years ago, and we're building on that, why do you think that hasn't happened? Because can we tackle what are the barriers to that happening? Because what you're saying sounds perfectly logical.
Yeah, I mean, it has happened for some issues, for longer term issues like climate change. So we are seeing experimentation with citizens' assemblies and citizens' juries there, which share some of the qualities of this pandemic. They've got high uncertainty, difficult decisions need to be made and so on. But what we hadn't seen was a building in of that kind of mechanism that you could turn on quite quickly with this pandemic. And I suppose what happened at the start of the pandemic was maybe people didn't expect it to go on for so long. So, and I think if it's not going on for too long, you can probably get away with scientific expertise and informing policymaking and publics being more advised. But as you get to this point where you're seeing recurrent waves and things kind of worsening again, and repeated cycles, I think then you have to have these mechanisms for bringing publics with you. I'm not quite sure why we haven't learned those lessons, though, to be honest.
Okay, well, I'll give you a moment to think, because I'll come back to the three of you to ask one thing that you think practically we could do differently this time around going forward. But I'll segue to our Professor Justin Parkhurst now, who's Associate Professor of Global Health Policy at the LSE. Justin, a lot of your work builds on what Kat mentioned there about the democratizing of these decisions, but ultimately decisions are made by politicians. And I see a comment there in the chat about some of the dissonances between or divergence between what scientists say and what policymakers say, even when they share the same stage. And we see that recently with Chris Whitty and the politicians. So this is a real life example of this happening. What do you think is necessary to close those gaps? So why do we, I think we know why there's divergence, but there are these tensions, right? So we need to close the loops between science, the public, and policy to ensure that science advice is more effective. Can you tell us a little bit from your expertise what is missing in this space?
Yes, thanks.
No pressure.
Yeah, no pressure, right. Thanks for having me and asking. I'll do my best. I mean, I think we often hear people asking, was science followed? Or the question of why didn't the government follow the science? But to actually answer that, and this follows a bit from Kat, I think, we really need to know, and we need a way of making quite explicit the goals that government officials are pursuing in order to be able to judge whether or not evidence is being followed or whether it's being used well. Because if we don't know what they're trying to achieve, we can't actually say whether they're following science, whether they're using evidence well, or whether they're using the appropriate evidence to pursue those goals. And you can take, for example, say schools, which members of Independent Sage have often questioned why there seems to be virtually no mitigation efforts being made. And we need to ask and demand them to answer, what are the goals being pursued in schools right now? Because if we look at statements from the government, it's unclear at times. We sometimes hear statements about the desire to keep schools open or indications of the desire to protect children, which don't seem to align with the actions being taken. We also hear statements about evidence, such as when Education Secretary Nadine Zahawi to the media a few days ago said that he's heard from other MPs that mask wearing can impede communication and affect learning in the classroom. Now, that's a potentially factual statement, but that's not really based on robust evidence. A couple of my mates told me something is terrible evidence for, to justify government policy. But we don't actually know if the government is trying to reduce spread in classrooms, to what extent it's trying to, if it's trying to consider other things like educational outcomes, cost and cost effectiveness of interventions. We just don't know. And some people speculate the government's willing to allow children to get infected. And so without pinning down the government and clarifying what they're trying to do, it becomes very hard for us to judge whether or not they're following science or using evidence. Because when we show them evidence, like the data showing transmission in schools, and we don't see mitigation strategies, it really can mean one of three things. Either they don't understand the evidence, so it wasn't communicated well, or they don't get it. But another possibility is they do understand the evidence, but they're not pursuing the objectives we had in mind. So maybe they're not trying to minimize spread to an absolute low level, but they're balancing it with some other idea of social goals, some other idea of the public interest. And it might not be necessarily mine or yours, idea of the public interest, but in a democracy, you need to figure that out. What is the public interest and how are representatives pursuing it? The third option, though, is, unfortunately, politicians are sometimes not pure public servants, right? Sometimes they're self-serving. So they may understand and be aware of evidence, but they're pursuing strategies to benefit themselves, whether it's electorally, personal goals, or whatever it might be, or maybe they're doing that in balance with some considerations of the public interest. Now, we don't know that, and we can't identify that if we don't have a built-in process which demands that decision makers make their goals clear and make it evident how they're weighing up and balancing different social considerations, and in turn, which pieces of evidence are informing those decisions. And so we need that for both scientific scrutiny, but also democratic accountability. And that's why I think it's particularly worrying what you referred to, and Alice, at the beginning, that in the last 24 hours, we've heard some conservative MPs at the moment, actively attacking scientific experts and advisors, including the chief medical officer, for speaking to the media or speaking in briefings and giving opinions on what they think needs to be done. And, one member of parliament tweeted that this was a problem because scientists are not accountable to the public the way elected officials are. But I think it's really worth pointing out that no scientific advisor, not even the chief medical officer himself, are making any kind of binding decisions for the public. It's only the government and legislators who do that. And if in fact we require expert advice to provide insight into those decisions being made, and to force government to justify their courses of action or their courses of inaction. So to argue that experts and advisors should not be providing recommendations in the name of accountability is in fact an attack on accountability itself. Democracy needs transparency in evidence use so that we can say, look, evidence have said these are the implications of what you're doing, so why are you doing it? Do you have good reason for this? Are there other considerations which you believe are more important? If so, what are they? Are you representing the public well? So I think we absolutely need experts speaking to the media so that we can hold the decision makers to account and demand that they explain to us what they're doing and why they're doing it.
Thank you so much, Justin, for that. That really closes the loop really very nicely. And so I'm going to come back to each of you in turn now quickly, just for a very quick reflection on a kind of concrete practical action, because the reality is, as somebody mentioned earlier, we've been treating this pandemic as a little bit like it's almost over, but this is a protracted emergency, right? And this is why we're having this discussion now. In the context of Omicron now, this new variant brings a whole new wave of uncertainty, but we mustn't treat this as the last bit of uncertainty that this pandemic will offer, because we know this is going to go on for a while. So it's really critical, and we have an opportunity to shape, to do things better and to do things differently, for more kind of inclusive, trustworthy, and effective policy interventions that actually protect public health in the most comprehensive way. So maybe in turn, in the same order, James, Kat, and Justin, what would you think from your perspective would be one thing that you think will take us in the right direction in this regard, in the context of protracted emergencies? And particularly, as Kat, you mentioned, climate crisis. This is another protracted emergency that we'll be dealing with. So we do need to shape this better. So, James?
Yeah, well, just quickly, I mean, I think you've hit the nail on the head. I mean, the concept of emergency in this sense needs to be rethought, and I think in all sorts of areas, not just this, but one looks at awarding of contracts and other things. All sorts of things have happened under the cover of emergency that we wouldn't ideally want or expect to happen normally. And I think the longer this goes on, while not denying at all, as Christina's reminded us very forcefully and eloquently in this presentation, that it is an emergency, but it is also not an excuse not to tackle fundamental things that we know need to be done to the advisory system and elsewhere. For me, a big improvement would be more two-way deliberative elements to that advisory process, by which I mean, you guys are filling the gap, which is great, but arguably, the government system itself should be creating more mechanisms to be drawing in and engaging directly with the full richness and diversity of opinion out there. I don't mean just by opinion polling, I mean by proper deliberative engagement with public views.
Great, thank you. So better two-way deliberative dialogue. Kat?
Yeah, unsurprisingly, I'd say very similar things. I think we should look to countries that seem to be doing better on bringing public trust with them, with public institutions, with policymakers, and Finland's an example of that. And interestingly, Finland has a much more consultative approach to its policymaking processes inbuilt. Now, it's hard to change things quickly, but I do think we need these kind of citizens' juries, citizens' assemblies to explore the future, what decisions that we're going to make now about the pandemic. And if policymakers aren't willing to do that, I think researchers should be coming together to try and facilitate that. This group is doing a great job of conversations between scientists and publics, but we also need to try and bring that to policymakers, so it's a three-way dialogue.
Okay, so you upgraded James's from 2 to 3 three-way. And Justin, closing remarks.
Yeah, I mean, I think those are all really, really useful points. I mean, at this point in the middle of what's going on, I'd really like it if the media could start demanding politicians clarify their social considerations, what they're taking into account and how they're using evidence to get there. So, which outcomes are you concerned with? How are you weighing them up? How are you balancing trade-offs? And which pieces of evidence are you using in order to inform those decisions? Obviously, in the middle to long term, we can think about how do we refine our whole systems, maybe to build into them, institutionalize, processes and steps or best practices that should be followed. But right now, in order to have more transparency, greater scrutiny over the science, but as well as more democratic scrutiny over the choices being made. But at this point in time, I think the public and the media, have an important role to play to do this. And there are some members in the media who are very good at this, I'll say. But there's also a trend in a lot of journalism to simply report by repeating what politicians say. The prime minister said this, and that's the headline, and that's all you get. And I think that does a disservice. It's not rigorous, and it's not socially helpful journalism necessarily. The media and the public need to ask politicians when they're making these decisions to clarify which are the social concerns and the outcomes you're pursuing, how are you balancing between different trade-offs, which pieces of evidence are you using, and what sources of evidence are being used. And until we kind of institutionalize that in how we hold our decision makers to account, it's going to be harder to insist they use evidence or to judge if they're using it correctly.
Thank you. Thank you very much. And thank you to the three of you. I think there's really fruitful and engaging discussion and lots of food for thought. And hopefully going forwards, we can take some of that in to create this spaces for better dialogue between policy, scientists, public, pulling in public opinion in a more nuanced way, and more building a more institutionalized memory and institutionalized processes for more transparent and accountable decision making. So thank you very much. I'll hand back to Alice.
Thank you very much, Tolly. That's absolutely brilliant discussion. Thank you. Really, really fascinating. Thank you, Kat, Justin and James for that. And I think you're going to stay with us, aren't you, in case we have some questions that you might be able to answer as we move into the question and answer section. We're going now then to questions from the press and public. We'll be running on to 2:45 today, as we have lots of people here to ask questions. I do want to fit in as many as possible, so please try and keep those questions as succinct as possible. Just one question, please, per questioner. And I know that the answers will all be nice and succinct. So first up, we've got Graham Lawton of New Scientist. Graham, what's your question?
Yeah, thanks, Alice. Given the news on the ineffectiveness of 2 vaccines and the lesser effectiveness of boosters and the booster numbers that we've just seen, are we effectively back to square one of vaccine coverage at this point?
Thank you, Graham. Deenan, is that a question that you might be able to answer, Professor Deenan Pillay?
I think Danny could make a stab at this.
Okay, if you'd like to hand it over, Danny.
Yeah, I'd say briefly. You're well aware that 3 weeks ago, we, by which I mean mainly immunologists, were in a kind of state of despair when we looked at all those 32 mutations across spike. And since then, there's been so much data that's come out on looking at antibody coverage against Omicron that I think we've settled back to a position where after 2 vaccine doses, you'd be really extremely susceptible, like in that Imperial College paper today. I think for most people, most of the time, a boost gets you into the protective zone. So the simple answer to your question is we're in danger, but not back to square one. I don't think so at all. I think we're covered by the boosters.
Okay, thank you.
Thank you very much. Does anybody else want to comment on boosters? Professor Anthony Costello and then Zubaida.
Just to say, whatever happens in the lab, we have to watch the data and some of the evidence in South Africa, which is a very different population, suggests lower hospitalizations and lower deaths. We'll have to wait and see, follow what the trends are from Christina's data. I agree with Danny that there is no clear evidence that immunity that we have will not have some protective use.
Thank you, Anthony. Dr. Zubaida Haque.
Can I just add, Graham, that boosters are absolutely critical, I think, given what we know about 2 doses. But we shouldn't forget that there's still a lot of vaccine inequality around, starting from, as Christina rightly pointed out at the beginning, there's still very high levels of unvaccinated groups out there, some of course because they're children, but still very high levels, including 30% in London, regionally among ethnic groups, but also in terms of deprivation in the most deprived areas. And on top of that, even if you look at 2 dose, huge variation. So what I'm concerned about is all the focus is on boosters, but actually we've still got a long way to go with sort of second doses and first doses. And can I just add, importantly, in terms of fourth doses for the immunocompromised groups, because I know that's still a huge concern, and I don't think the government have addressed that.
Thank you very much, Zubaida. And I think Professor Cole-Friston, you wanted to ask a question.
If you don't mind, yeah. So to Danny and Deenan, just coming back to this sort of, are we back at square one? Is there any rationale for sort of thinking about two kinds of immunity? One, due to antibodies that prevent infection, and then another kind of immunity, T cell mediated, for example, that if you do get infected, that offers some protection against your clinically developing symptoms. Is that a distinction which sort of nuances, are we back at square one, sort of worries?
Thank you.
I mean, if I could start, sure, it's I'd love to talk about more and more detail on T cells and antibodies, but it's kind of not helpful, is it? Because it's the baseline against which we all work now. So every time you're infected, you induce your B cells and T cells and antibodies, and every time you're vaccinated. And what can I say? That accounts for the fact that we're not doing even worse at the moment than we are, and don't have even more through the roof hospitalizations than we do at the moment. But it doesn't buy us any kind of secret mitigation. It is what it is. It's the level we have.
Thank you very much, Danny. Do you have anything to add there, Deenan?
Just very briefly, I mean, we've got to remember that we were pretty much naive population, the world's population, to this virus, of course. And you, Carl, were part of these early discussions of where there was any sort of residual cross immunity back from other coronaviruses. I'm not sure how far that data that's really got, but we've gone from a situation of naivety to, and we've seen a new pandemic really, and how that's evolved. And of course, now that there is levels of immunity, as Danny's sort of described, different vaccines, different exposures. And of course, the more exposures there will be, and what that means is coming up against the virus in whatever way, that having some sort of boost the immune system, I think we're in a very, very different situation now than we were before. So the idea of sort of going back to the start, I think now we're well on train to have a sort of a level of population immunity of some form, which will attenuate things compared to the complete naivety of the immune system at the beginning. Speaking as a virologist, that is, rather than an immunologist. Apologies, Danny.
Thank you very much. It's a really tricky question, isn't it? And one of these questions that I think we've really kind of tried to grapple with since the very beginning of this, the difference between individual choices, individual risk, and population risks, and how different those two things are.
Can I ask a question?
Yes, you can.
What about?
But there are lots of other questions coming in.
Sorry, original antigenic sin. This idea that as you vaccinate more and more, it doesn't work as well because you're always responding to the original virus rather than the new one.
Danny, would you like to take up the subject of original
sorry,
antigenic
I feel like I'm hogging this. So have a look in Science last week where we wrote about it. So all I'd say is it's complex, isn't it? Because we still imagine, when we talk about vaccines, that we've got a sort of tabula rasa like we did 2 years ago, where you can bung in any vaccine to anybody and it'll have some new protective effect. And that just isn't so, because we've got a very diverse global population now who've met Wuhan or Alpha or Beta or Gamma or Delta or Omicron, and if they're lucky, a vaccine. And we've all got different immune repertoires, and we're all going to respond to oncoming variants in different ways. So just what needed to decode that. And not just jump on the next vaccine thought of. Yeah.
Sorry, just missed the conclusion there. I think your internet connection just dropped at that very last phrase.
It was just that when I say it's complex, I don't say that in a sort of hopeless way, but in a kind of you can't just jump on the last variant you heard of and make that into a vaccine. You actually need to take this background into account.
Thank you very much. Thank you for all those questions. Let's move on to another one now from Kevin Courtney, the General Secretary of the National Education Union. Kevin.
Thank you, Alice. And I wanted to just start by thanking everyone in Independence Age on behalf of the nation's educators for engaging in the science with the public. It's very difficult in schools at the moment. We're reaching the end of term, but it's been very difficult, very disrupted. On December the 9th, the data was that 230,000 children off schools with COVID, lots of staff off as well. The ONS data suggesting that 37% more chance of testing positive if you're an education worker than the general population. And that's clearly because the cases are so high amongst children. And that leads to my question. My question is, what's going to happen in January? What is the forecast of where we'll be? Because all of those figures that the figures I was just talking about are figures related to Delta. So what do you think schools will be facing in January? How much can we know now? How long will it take to know more? And I know Alice said one question, but what mitigations could easily and quickly be implemented? What contribution can air filtration and ventilation and face coverings or masks in classrooms, what contribution can they make? How much does it matter that siblings of children who test positive should isolate rather than doing a daily test? Is there a real contribution that those mitigations can make to whatever situation we will face in January?
Thank you very much, Kevin. So yes, you've asked several questions there, but let's break it down to two. So first of all, predicting what's going to happen. And it is only 2 weeks, isn't it? So in 2 weeks' time, when schools are back, what's going to happen? Christina.
So I suspect we'll see a really big Omicron wave in schools. Children are largely under vaccinated or unvaccinated. We know that actually previous infection is not that protective against Omicron. So that's not, this idea that children can get herd immunity and be fine. I don't think that's going to be borne out. I think fresh, clean air is the most important mitigation that we can have, given they're inside all day. Masks will help, but they can't do it on their own. I think every classroom needs a CO2 monitor so that teachers can monitor and tell when they have to open the windows and let fresh air in. Where you can't do that, HEPA filters have been shown to be effective. They're quite cheap. You could do every classroom for a few £100. On the context of what the government's got on the pandemic, that's not very much. Now, you can't do it all at once. We just don't have as many filters available. But you have to start. If you don't start, you'll never finish. And I think, if a child has someone in their house who has COVID, that child should isolate. That like sending people into schools, anyone who's a household contact of someone who has COVID should be isolating, and that includes children. So those are the things that I would suggest.
Thank you very much, Christina. I think you parcelled up both of those questions brilliantly. Does anybody else want to comment at this point? We've said quite a lot about schools in the past and mitigations that would help. Susan, I wonder if you would like to just add to that, Professor Susan Mickey.
Well, I think the only thing I would add is how are we going to achieve these things? There's 2 weeks, and then the term is going to be really, really difficult. And I know there have been lots of voices, lots of prominent voices and prominent groups. But so far, we haven't seen a national response at government level. My only sense, and I think I have said this before, is really to bring groups of people together as much as possible to make an even bigger noise and a bigger voice than we've had up till now, and make sure that parents, governing bodies, teachers, children themselves are making these kind of demands, because we're not sending our children in to schools to drink poisoned water. So why should we be sending them into schools to breathe poisoned air? So I think it's that sort of campaigning really that's got to happen going forward.
Thank you very much, Susan. And we're 2 years into the pandemic now. Things that we knew would have helped early on. Installing filtration, adequate ventilation into classrooms in the summer of 2020, we know would have made a massive difference, and we still haven't done anything about it. We do need to make a bigger noise about it, clearly, and we do need to group together and do this cooperatively. Thank you very much, Kevin, for coming on today. We've now got Robert Dias to ask a question. Robert.
Hi there. I'm Robert Dias. I'm an oral surgeon. I work in both primary and secondary care. And I think since I put my question in, you probably answered it. It was really looking at Omicron and the data that kind of a week ago was coming out, particularly from South Africa, regarding the virulence didn't seem to be as bad. But I think you probably answered that already. And I certainly, from a dental point of view, a lot of my colleagues are concerned about whether perhaps there's an overreaction. But as I say, from my point of view, I'm probably reassured from what I've seen that you've actually answered that. But would it be possible to go on to a second question? And that's to do with mandatory vaccinations, which obviously we as healthcare workers all have to do and comply with. And that's causing significant problems and will do come next, February, April, when they have to have the first vaccine. I know 30% of dental nurses haven't so far been vaccinated in England. Do the panel agree with mandatory vaccinations or?
Thank you, Robert. So, Susan, back to you.
Yes, I mean, it's a very good question. And the answer is that we don't agree with each other. So we do have rather different perspectives, which I think reflects where we're coming from. But certainly, in my role in SAGE's Behavioural Science Advisory Group, one of the things we've been saying time and time again in terms of vaccination, other measures, is the importance of engaging communities, ensuring that people have trusted people to speak to raise their concerns with, ensuring that there's no barrier in terms of taking time off, in terms of sick pay, when people have to take time off because of symptoms afterwards, ensuring that people have easy access, enough digital literacy and support, managerial support, etc. Now, maybe with your colleagues, none of these things are, or the latter things in terms of opportunity aren't the case, and it's more to do with motivation and getting reassured. But I think one of the important things is not to back people into corners, not to in any way downplay their fears and concerns, but say that we have new evidence. This is a new variant. We're in a new, different situation, and share that new evidence about effectiveness, about safety, that can address those concerns. So my own view is that there are so many downsides of going down the compulsory road in terms of demoralization, divisiveness, losing important staff to key sectors, that we should do all these things that we know make a difference and that still haven't been done. And I have to say, the government has to do this with resources and drive at a national level.
Thank you very much, Susan. I wonder if I could just ask a question back, because it's a while since I've been working in the clinical arena. But Robert, is Hep B vaccination still mandatory?
They are,
for healthcare
yes,
workers.
They are, even though I've never seroconverted, but there you go. Yes.
Yeah. So it's not an unprecedented situation to ask healthcare workers to be vaccinated.
I would agree with Susan completely. I think the issue is that making it mandatory, it backs people into a corner. It's beating them with a stick rather than giving them a carrot. And the information out there, particularly on social media, as we all know, can be unusual, not always particularly accurate, and that's a real problem.
I think Professor Anthony Costello wanted to comment as well.
Sorry,
and Martin as well.
Just to say, I mean, I agree with Susan and the questioner. Sorry, I've just lost you. Robert.
Robert.
I agree with you for the general public, but when we become health workers, I was taught your duty was to cure sometimes, relieve often, and comfort always. And the other principle is primum non nocere, first do no harm. And I believe that we're in a privileged position, and therefore that comes with that are responsibilities. And I think there should be mandatory vaccination for health workers. The problem arises with care workers, whether they fall into the same category. But I think if you are a health worker looking after patients, given the severity of potentially transferring this, I think you should be vaccinated.
Thanks, Anthony. Martin, you wanted to add something quickly as well?
Yeah, no, Susan's absolutely right in that we don't agree among ourselves. And I'm not sure that I actually agree with myself over time, because my view has somewhat changed on this, because I was very much in the, opposed to it. But I sense that across Europe, there is a changing view about this, which is beginning to say, well, if we can't open up society, if we're going to have to live under restrictions when so many people are not being vaccinated, then there is a societal response. And I think we also have to differentiate those people. First of all, I totally agree with Susan that we can do an awful lot more to make a vaccination easy for people. But I think the work that Melinda Mills out of Oxford did recently with a synthetic control study showing that having vaccine, let's call it COVID certification, did have a positive impact in getting more people vaccinated. And that was a sort of nudge in a way. And I know there are all sorts of problems with that. So I think it is complex. And I think it's changing. But in general, I think we're sort of largely agreed on the principles, but I know that my views are drifting a little bit further away from the rejecting it completely to at least starting to think about where we might be in the future.
Thank you very much, Martin. Thank you very much, Robert, for your question. Moving on now to a question from Louise Flanagan. Louise.
Hello. I wanted to ask about the infectious period for COVID. I know more families now with COVID, sadly, than I have since March 20 before we went into lockdown. A lot of them have children in primary schools. We're really struggling with that. Obviously, a lot of those families will be hoping to see grandparents over Christmas, and some of them it will be quite tight on the isolation period. So I was wondering, if someone has COVID, are they definitely not infectious after their 10-day isolation period once they've done their test and they're 10 days from test, or could they still be infectious after that time? How careful do they need to be?
Thank you very much, Louise. It's a really interesting question, isn't it? Because of course the isolation period used to be 14 days and then it was dropped to 10. And I don't know if that was a political or an economic or a scientific decision. But have we got expertise here amongst the panel? Could somebody still be infectious after 10 days, Deenan?
Well, of course, in health and medicine, you never say never. And the danger is all it takes is one illustration of someone who is secreting virus from their nose and throat for longer than that period, and suddenly it bursts open. Everyone says, "Oh, what about this?" So I think we've got to be really careful about this. And of course, there are very, very rare instances of people generally who have got compromised immune systems that if they're infected, they can excrete the virus for longer than that. But of course, we're here talking about public health measures and things that are very likely to work. And I think 10 days is a fair period of time. And of course, but again, what we're seeing, is a bit more of a pragmatic view in terms of how to use testing, during that period to check. And so as of this morning, certainly there's health service a health service memo that has gone around to address the issue of where frontline health workers are in contact with COVID, which of course is debilitating the health service workforce at this moment in time. And the change is that individuals would be asked to test themselves each day and be working until they become positive, rather than taking 10 days off. So, for instance, that's a pragmatic approach that is starting to be used. But I think with regard to the more social situation, Louise, that you're talking about, I think also be guided by the vulnerability of those you're going to be around. So that's my sense, is that yes, that 10 days is an appropriate period of time, but testing can also be useful and reassuring in cases where you really feel that you may be putting someone at risk.
Thanks very much, Dean, and thank you very much for that question, Louise. I want to bring in another question now, which just links up with something that you just mentioned, Deenan, and the questioner is Richard Abendorf. Richard.
Hello, can you hear me?
Yes, we can.
Thank you for taking the question. Yes, according to brand new government guidelines, staff can work even if someone in their household is infectious with COVID. Now, given the spread of the variant in hospitals are showing, given the age profile of those with infection and vaccines, and the reality that only paper surgical masks are available still for many staff. Rachel Clark recently tweeted on this. Given all this, surely this is exactly the wrong policy needed at this time. It's going to spread the virus to NHS staff and the public who use it. Or is the answer, this is inevitable and tragically needed because once again, the NHS is overwhelmed and it reinforces the need for this immediate circuit breaker. The big learning question is, how can we be at this situation yet again? And what should be done differently for virus suppression?
Thank you very much, Richard. Helen, I think you'd like to answer this one. Dr. Helen Salisbury.
Hello. Yeah, how can we be here again? I think that's a question that maybe our earlier guests who were talking about engagement with science or politics engagement with science would have an answer to that, maybe not a very encouraging one. I think we have a really difficult situation because with the spread of Omicron as fast as it is now, we are going to run out of health workers really quickly if everybody is isolating. On the other hand, if they come in when they have family members, we do know that people sometimes spread it before they test positive themselves. So we're in a really very difficult situation. The first thing we should do to protect both those health workers themselves and their patients is be using very, very much better quality masks than we are now. Most health workers only have the fluid resistant surgical masks, which provide a little bit of protection from passing it on to other patients, but they're not as much as we need. We really need to be protecting both patients and staff by using higher quality, higher filtration masks, really in all clinical settings now, and that's something we could be doing right away. It's very difficult to know how we square this circle of having so many people isolating, but there's no one left to treat the patients, and the risk of staff actually infecting patients because they've got a family member at home with the virus. But better masks would help.
Helen, presumably it's an economic thing, is it? Is it simply a cost thing that P2 or P3 masks are more expensive?
They're more expensive, but not more expensive compared to treating people who are really ill. Yeah, it's such a false economy to save on things like masks, which aren't that expensive. They really aren't, and then have to treat a whole load more people. The disregard, I think I've really felt for people from the teaching profession earlier. That there seemed to be totally their safety and the safety of children in schools has been so disregarded. But I also think the safety of NHS staff has been really, really put on a very low priority. And if that was something that you were valuing, then you would do what Cambridge has done, because at Addenbrooke's Hospital, they've done a very interesting experiment where they gave everybody decent masks and they saw their infection rate absolutely plummet in staff. It's possible, there is evidence there, it's just not happened, and I can see no excuse for it.
Thank you very much indeed for that, Helen. I think I'm going to have to wrap it up there. We had lots more questions, but we've had an amazingly wide-ranging discussion. Thank you very much, everybody, for your questions. And thank you very much to our amazing panel as well, of course. And thank you too to our guests today, Kat Smith, Justin Pankhurst and James Wilsden, for the discussion about science and policy making, which seems very, very pertinent this week. And thank you very much, Independent Sage, for all your hard work through the pandemic. You can now have a couple of weeks off before the next Friday briefing, but I suspect that you will be working on through. Picking up just on something that Professor Kat Smith said, just to wrap up, it's not good enough to try and second guess what the public will or won't be prepared to do to help manage the pandemic. And in fact, Steve Reischer, before he had to leave before the end of this rather late briefing today, messaged to say the government can't argue that they can't act because the public won't wear it. The evidence shows increasingly that many more people want action than oppose it. For things like mass events and nightclubs, the support for action is absolutely overwhelming. What's more, even in the absence of government direction, many more people are changing their Christmas plans. As of yesterday, 61% had already done so, or were thinking of doing so, up 5% in 3 days. So it seems that the public is ahead of the government once again. As Christmas draws nearer, there are things you can do to keep yourself safer, to relieve the pressure on our NHS, which is under a lot of pressure. There was a report published in The Lancet just today saying that we are likely to be in the situation of cancelling 100,000 operations this winter if this surge goes through unchecked. You also want to be able to spend the time with people who really matter over Christmas. So do have a look at that Independent Sage emergency plan that Christina summarised at the very start. That's up on the website. We'll be back in the new year. Until then, Yuletide greetings from all of us. Stay safe and keep well.
Bye, everybody. Merry Christmas.